Good morning. We are in the office of Dr. Stephen Sandler, who is an 1975 graduate of the British School of Osteopathy and is a PhD. And I'm very glad to have this time with you, Steve. Dr. Sandler was one of the first friends I made coming to the BSO through a long comedy of errors that I will leave out of the tape. And this is a real pleasure, Steve. Thank you very much.
Pleasure's all mine. Thank you.
Dr. Sandler, why osteopathy?
Oh, by accident. Completely by accident. I was never wanting to be an allopathic doctor. In that sense, I didn't fancy the GP route, and I didn't fancy the ladder climbing that hospital practice entails. I enjoyed people, and so I did 2 years studying to be a dentist. And after 2 years, I realized that I really couldn't face the rest of my life with people hating me. And so I said to my father, I'm really very unhappy about this. And he said, well, I haven't got a lot of money. He was a London cab driver. But he said, whatever I've got is yours, but the rest of your life is important. And I looked around, and I fell upon osteopathy totally by accident. I was actually going out with a girl who was a nurse who'd hurt her back. And I went round to see her, and she was in terrible trouble. And a week later, I went round to see her, and she opened the door. Oh, this is interesting. Who have you been to see? Oh, I've been to see an osteopath. What's that? And it was actually Laurie Hartman. And he doesn't remember anything about this at all. But I phoned him up and said, did you take an apprentice? And he said, no, it's a 4-year full-time course of training. I arrived at the BSO, where I was interviewed by Colin Dove. I thought this was fascinating. I thought this was very interesting, and I wanted to give it a go. And Colin said, well, can you make up your mind? Today's Friday, and we start Monday. And so I started on the Monday morning on the course, the 4-year course, and quite honestly, I've never looked back. It's been a hand and a glove, as far as I'm concerned. It fits me beautifully.
Dr. Sandler, how did you know, or when did you know this about yourself, that you wanted to be involved with people in a very deep way, as you are?
I don't know, is the answer. It's been pointed out to me since that there's no coincidence that I'm a successful osteopath and that my sister is a very successful psychotherapist. And there's obviously something in our background that leads us towards wanting to help other people. I discovered that a long time after I was qualified.
This question that I want to ask you, I've been asking everyone on this trip because there's some stark differences, as I know you're well aware, between the States and between the UK. So in the States, I've asked people about manipulation in osteopathy because it's so far removed from current osteopathy, although not from the older generation that I've interviewed. They were, of course, going to be hands-on osteopaths, as you are. But for perhaps a younger generation that might view osteopathy as manipulation, how would you answer that?
Very easily. Manipulation takes 3 seconds. Treating a patient takes half an hour. 29 minutes, 57 seconds, that's osteopathy.
Let me get a bigger answer from you. That's a great answer, but let me draw a little bit more from you.
Osteopathy is not a technique. Osteopathy is a way of seeing people, is a way of evaluating the whole person. Mind, body, spirit, the lot. And then it's a way of contacting the tissues that are, if you like, the pain generators. The tissues that are crying out for attention. Now, they may be obvious to the patient and they may not. But if all you do is go symptom chasing, then osteopathy really isn't being practiced. But osteopathy, to me, is a way of finding out why this patient, why this problem, why this time, what's happening here. And that gives me an opportunity to approach health. And health, to me, is what osteopathy is about. It's looking at making patients better at coping with what they've got, even if they've got an incurable problem like a degenerative hip joint. You know, I've got patients who have been coming to see me for over 20 years. And they keep putting off their operations because they don't need it yet. And they have a good life, they're mobile, they're self-sufficient, and they tell me that this is what osteopathy is all about. They say to me that they need osteopathy to keep them healthy. And if I've done that, then I've been successful in my ambition.
Thank you for that expanded answer. Steve, we were discussing off camera your research that you did for your PhD,
Yep.
which I find very fascinating. And actually, one of the things that I was very drawn to you when we first met and discussed things, aside from you torturing me in a small room, asking me to demonstrate pelvic technique, which I may as well give the short story. You asked me to demonstrate some pelvic technique, and I had a young lady sit down, and you said, "Wait a minute, how can you do that?" And she's still dressed. And I said, "Well, in America, this is how we do it unless we have a team of lawyers standing over here." And I think it went downhill from there. So you have such a deep perspective of your experience in the female perspective and obstetrics and gynecology and how this relates to osteopathy, in particular to your research. So I'd like to just open up the can of worms a little bit to tell us about your research, what you've done.
Well, my research started a long time ago. It actually took 11 years for the whole project to be completed. I've contacted the Guinness Book of Records. I'm not quite sure if it'll pass. But the idea came when I noticed that people were coming in to see me, women, within their reproductive life, and saying, "I didn't do anything. All I did was bend down and pick up a piece of paper. All I did was turn to look at the kid in the back of the car, and bang, everything happened, acute pain, what's going on?" And this was happening very frequently, and there was no explanation for it to be happening. And it intrigued me, and so I started to try and find out what's going on, and asking them lots of questions about lifestyle and what's happening here. And because they were all female, I started to ask them, at what stage in your menstrual cycle were you when the incident occurred? And realised that a lot of these women were either mid-cycle or premenstrual. Now, there's a fair bit that's been written about premenstrual back pain, but with poor explanation. Was I the only person seeing this? I sent out a questionnaire to 1,000 osteopaths, got back a high proportion return, and put the numbers through the computer, and bingo. The curves are absolutely clear that day 12, 13, 14, okay, you're going to have something like a 27% peak, and then day 26, 27, you're going to have another peak. And this was fascinating, especially when we found also when analysing the responses that pain was lumbar pain mid-cycle and neck pain premenstrual. Why? Nobody knew. So, okay, fine. I set off on my quest. And it started as a master's, which was then converted to the doctorate program in conjunction with the academic obstetric and gynae department at the University College Hospital at the Chelsea in Westminster, and who I'm very grateful for because they paid all of my analysis costs. So we had to say, okay, what was actually happening? And we devised a series of experiments where we recruited volunteers who had a predictable and regular cycle. Well, that was the first joke, because everybody will put their hand on a stack of Bibles and say, I'm as regular as clockwork, no problem with me. But if you actually want to do a blood sample specifically on one day, and they come back to, oh, I'm sorry, I was a day early this month. I was 2 days late this month. Then all your readings are gone. So we started out with about 70, 80 volunteers, and we actually came down to 17 who had predictable data. And we measured the movement at the metacarpophalangeal joint, because it's got nothing to do with the gynae system. If this was a change, it was going to be a global change. And we took blood samples and we looked for estrogen, progesterone, and relaxin. And the results were staggering. We found that every woman, every month, gets looser and looser and looser as she approaches menstruation. But at the first half, from 0 to 12, the peak is very steep. So she may start off with 35 degrees of extension, and then by mid-cycle, that's gone up to 55 degrees. Okay, and
Steve, let me just ask you. Let me just interrupt for 1 second. How did you decide on that you would look at the
that was
carpal
easy.
joint for that?
I went up to the University of Leeds, and they'd devised a specific machine which accurately measures that joint.
Okay.
And we're using the Leeds hyperextensometer. It was a very easily reproducible piece of kit. So measuring that is easy to identify to the nearest degree. Looking at the bloods and then correlating the data. We found that in the first half of the cycle, as estrogen rises, so laxity rises. We found that towards the mid part of the cycle and then the end of the cycle, progesterone comes in and laxity doesn't change very much. So the villain of the piece that for years had been pointed at, progesterone, is totally innocent. But then we found that relaxin, the pregnancy hormone, is present in every woman, every month, for just 12 hours. Why? So that the cervix can open and so that she can menstruate. It's as easy as that. We then looked at men and found that the guys didn't change at all. Absolutely flatline, didn't change at all. Why? Well, because they don't need to. And the interesting thing that we found in men is that there's no relaxin in their blood, but it is in their semen. Because if, when he ejaculates, the semen hits the cervix opens, sperm swims through. Or to put it another way, structure governs function. And it's a beautiful illustration of a sound osteopathic concept. We then looked at pregnancy and found that all sorts of old wives' tales about primips and multips, about whether you had your baby, you'll be okay next time round. It's not true. Every birth's totally different. We found all sorts of things about, oh yes, relaxing comes in the third trimester. It doesn't. If you're very stiff, with a thing like, for example, ankylosing spondylitis, it'll come in very, very, very early as week 6 or 7, so that your body can adapt. If you're wackedly hypermobile, it doesn't come in until the very, very end. And then we looked at whether lactating women are going to be hypermobile in comparison to the norm and therefore prone to injury. And then we looked at HRT, just to finish it off. Those people on HRT retain their laxity, and those that don't. And it's all to do with estrogen affecting skeletal muscle and relaxin affecting the collagen within the ligaments.
What did you find? What were your findings with lactating women?
There was no, in that particular sample, it was too small to actually give a valid response. But certainly, clinically, I've found that I am very, very happy, obviously, for people to breastfeed. But for about 6 months, and after about 6 months, there is the potential for permanent change.
Fantastic, Steve.
It was an interesting journey, and one of which I thoroughly enjoyed, as you can hear from my tone of my voice.
Yes.
And it was, it cemented osteopathic principles right there and then.
Fantastic. Let me ask you. Let me switch gears a bit. Many people have talked about the concept of a key lesion. Is that something that you use? Is it something you find relevant? Is it something? What are your thoughts on that?
I've heard the concept. I've heard the concept discussed by many different people who practice classical osteopathy. I remember talking about it when I was a student. I don't think I've found it, and the reason why I don't think I've found it is because I don't think I've looked for it that hard. I know that what I do when I examine my patients is I try to make a specific attempt not to hone in too early. So I get as big a picture as I can get and find out where the contributions of the visceral system, the craniosacral system, the somatic system are to the presenting patient, not necessarily to the presenting symptom, if you see the difference between the two. And then go in and have my treatment program based on my findings. But the concept of a key lesion, I think, is a little too slick for me. All you have to do is go and find the key lesion, and that's it. No, I think it's a little harder than that. And I think that not to be critical of my colleagues, but in my teaching, I try and teach the students to keep their eyes open and to keep their hands light. Palpation is the ultimate truth. It never lies. It never, ever lies. A student might say to me, Dr. Sandler, am I feeling this? I've got no idea. I'm not on the end of your hands. But I'll feel something. You feel something, and let's discuss our findings. Now, if that relates to a key lesion, all well and be, but I won't use the term personally.
Okay. When a patient comes in to see you and they give you their chief complaint, whatever it is, how relevant is that in what your treatment may turn out to be?
Oh, it's very important. Again, to use another analogy, if you go into a shop to buy chocolate and come out with a new sweater, you're not very happy. Okay. You know, patients come into us and they're suffering, they're in pain. Our duty is to address that. Now, there's a short-term and a long-term aim here, but the short-term aim is very important.
Let me clarify it a little bit then. I do understand the chocolate and the sweater, although if you come out with chocolate and a sweater, maybe
then
you're okay.
Win.
If they come in with a chief complaint and they say, I'm having lumbar pain, and in your examination you find some findings for that, but you find a lot of findings for something else in the cervical, elsewhere in the body, does the chief complaint have the same priority to you as it does to them?
It may not have the same priority, but we have to have a contract of treatment. I have to be able to say to that patient, okay, you're suffering from a lot of lumbar pain, but really the reason why you're suffering a lot of lumbar pain is that whiplash injury which disturbed the occiput and developed the scoliosis. And as long as that patient understands why I want to do what I'm doing, then we have a contract and we can treat. But to simply not explain why I'm doing what I'm doing is just bad practice. And I might very well not address the symptom picture. As I said to you a while ago, symptoms are important, but it's the why that's important.
Steve, who inspired you when you were a student?
Some of the all-time greats. Some of the most wonderful people who aren't with us anymore. I remember Clem Middleton of blessed memory. Wonderful, wonderful man. Laurie Hartman, who I think is one of the greatest technicians that's ever walked the earth. He has the ability to use his hands and use his body as well as explain what he's doing, which is something that people just can't do. People like Audrey Smith, Colin Dove, Billy Naidu, these were people who, to me, were my teachers, were my mentors, and I'm eternally grateful for what they taught me. And I think my patients are too.
Do you feel you're different than the people that taught you?
Yep.
How so?
Because I discovered that the way we were taught was done in a specific way. But when I started working and teaching in Europe, I started to see a bigger picture of osteopathy, where the viscera, the crania, and the fascial systems were incorporated into a greater concept of a treatment plan. And so I've incorporated that into my teaching as well as my practice. And this completeness, this expansion of the osteopathic concept will be producing practitioners in the future that are quite different to the practitioners of the past. And that's okay, that's good, because it means that we're changing and we're evolving. And I think that in the UK, we have the facility to take osteopathy into a totally new generation. The clinic at the BSO is currently treating over 1,000 patients a week, and that's the students that are doing it. Broad range of treatments through pregnancy, old people, handicapped kids, sports people. There's an HIV clinic. There's a clinic in the church for people who are indigent in the streets. Now, we didn't get that exposure. We had a clinic that was treating mainly musculoskeletal medicine. That's changing, and if I've been part of that change, then I'm very proud.
Dr. Sandler, do you have a thought, aside from the chief complaint that they present to you with, do you have perhaps a deeper thought as to why people become ill, or they have imbalance, or they're sick?
I do, and I think that we have to be prepared as practitioners to address issues that are fundamental to life. And by that I'm talking about this whole mind, body, spirit concept. I think there is a spiritual dimension to pain. I think that there is a a way that people present themselves because they may be spiritually or emotionally damaged. Don't forget, our very first exposure to medicine was love. When we fell over and banged our elbow and went crying to Mum, she rubbed it better and gave us a hug. And unfortunately today, allopathic medicine sits the wrong side of the table. Doctors don't treat anymore. The pharmacy treats, the surgeon treats, the nurse treats, the osteopath treats, the physiotherapist treats. But doctors diagnose. And patients are in the forefront of a patient-led revolution in terms of complementary therapy because they want healing. And that might not be a pill for every ill and a potion for every emotion. They might want something which is more valid. And what we do, fundamentally, is we touch. And that touch is part of love. We love what we do. And we love our patients in that sense. And I think that restores a spiritual component which is missing in medicine. So I think there is a very deeper way in which osteopathy is working.
That's a great answer, Steve.
Thank you.
Really deep answer. Steve, have your challenges or your inspirations changed throughout your career?
Oh, yeah. Absolutely. Because I still don't know why these patients are coming to see me. I still don't know how I'm getting them right. And it's a daily challenge. It's a challenge for me every half an hour when I change patients that I might know that patient very well, or I might think I do. And to me, it's a constantly changing and evolving and a learning process. You know, as I say, I might think, oh yeah, okay, that's this, that's that. I can do this. And the patient comes in next time. How are you? No good. Absolutely horrible. I don't know what you did to me last time. So that's a learning process. Or, well, you know, this is going to take us at least 6 months of once a week, and I'm not even sure then as to what we're going to be able to do with you. They come in next time, how are you? Fantastic. I don't know what you've... it's this constant challenge. What are we doing? Just to illustrate that, if I may talk about a case that I'm currently treating.
Please.
I would venture to suggest it's one of the most important cases that I've ever come across. It's a guy who's 38 years of age who 2 years ago came over the top of his motorcycle and was severely injured. He fractured C6, C7 and T1. There was a syrinx, a hole in the cord 3 centimetres long. There was a complete avulsion. He'd ripped his brachial plexus clean out. Sorry, that's for the edit. He'd ripped his brachial plexus clean out. When he came to see us, he'd undergone, I think it was 14 hours of surgery at the Hospital for Nervous Diseases in London to reattach the brachial plexus. He'd had a year of physiotherapy, and they said, well, there's as much as we can do for you. He was taking 21 tablets a day, including the maximum legal dose of morphine, gabapentin, and paracetamol with codeine. He had a phantom limb coming out of his arm that he described as being boiled in hot oil. He hadn't slept more than an hour because of the pain. The whole arm was totally useless, and it was just a dead piece of meat. He arrived at the BSO because he'd said to somebody, I'm going to try an osteopath, and they said, well, what have you got to lose? And unfortunately, he arrived at the BSO on the day when a student was taking his final exam. And this poor chap came in, his head, by the way, is stuck on the side because to provide traction to the plexus if it's going to heal. And the poor student just didn't know what to do. And when the examiner said to the student, what are you going to do with this patient? The student said, I'm going to give him to Dr. Sandler. And I think he passed the exam because he knew what he couldn't do, which was very interesting. So we started treating him. And I treat him on a Friday afternoon clinic, which is a demonstration clinic where I work with the patients and the students are watching. I realized from the outset this was going to take more than just one person. So I brought in a colleague, Trevor Jeffries, who he worked with me. I was working from the top end and Trevor was working from the bottom end. And we took 2 students. So I've now got 2 students' hands under mine, and he's got 2 students' hands under his. So there's now 8 hands working with this guy. And the first thing we did was to feel what's going on. And what we found was a block of concrete here. There was absolutely no communication between his centre and his periphery. Using fascial release techniques, using craniosacral techniques, using balancing tension techniques, we've been working with this guy now for the past 14 months. The results, to say the least, are spectacular. And I mean spectacular. Within 3 treatments, the phantom limb had gone. He was sleeping 6 hours a night. The first time he slept 6 hours, he woke up screaming because he'd missed his medication. And I said to him, I'm awfully sorry. And he said, no, do it again. And we've been working ever since. This guy now has cervical movement. He has shoulder movement. He takes 1 gabapentin a day. That's it. And he's thinking of changing that for his paracetamol instead. He's happy. He comes in by himself before he had to be driven in by somebody else. He's alive, he's bouncy, he's everything that health is going towards. And those students have had the opportunity to see that happen and to feel that change. When we put our hands on, we can feel those tissues talking to each other and communicating with each other. And it is the most exciting thing. I come out of that treatment room and the students just look at me and say, wow, I didn't know osteopathy had that potential. And I say, yeah, well, neither did I. So that's a very personal thing, but it's a wonderful opportunity to actually say, well, that's what osteopathy can do.
That's a fantastic story.
I'm going to write it up one day.
Steve, how would you describe that when you're evaluating a patient, that information comes into you? Would you say that it comes in through a particular organ, a sensibility, palpation, integration in your brain?
Well, first of all, you listen. The first thing I do is they sit down, name, address, biographical details. I put my pen down, I sit back in my chair and I say, why are you here today? You have to listen, you have to hear what they say. That gives you an idea of who they are, what they are. It gives you an idea of the tissue presenting. It gives you an idea of the environment that tissue lives in. They may come in with muscular pain but have an underactive thyroid. So you have to be, as a primary care practitioner, responsible for primary care diagnosis. That's the way we work in this country. And then I'll evaluate. I'll evaluate with a palpatory approach. And that palpation is a global palpation. I'm feeling for movement in all different levels. I'm feeling for movement within the brain. I'm feeling for movement within, not necessarily within the brain, within the skull. That's a better description. And I'm feeling for movement within the craniosacral system, within the visceral system, because movement is life. We're not osteopaths, we're movement paths. Living things move a lot, dead things don't move very much. And therefore what we do is evaluate motion. And we evaluate motion in every different way, because the more we can then improve on that motion, the more that person's living. You know, kids run around all day long. Their motors never stop. Granddad spends most of his time sleeping. So what we have to do is evaluate the living motion. And that living motion is fluid. Still said, move the fluid, boys. In the CSF, in the arterial system, in the lymphatic system, and in the gut. And what we should be doing is improving motion, because when you improve motion, you improve fluid. And when you improve fluid, you improve health.
Steve, that was a fantastic case that you had just told me. Can you tell me about a case, pick one of many that could pop up in your filter, of a case that went so well, but you really have no idea why it went well? Or something that left you scratching your head afterwards?
Yes, I mean, it happens almost on a daily basis sometimes. That, you know, the patient comes in and you... Well, yes, here's a nice example. A young woman was referred to see me at the hospital, and she was 26 weeks pregnant, and she had very serious pain and she had sciatica. She couldn't move that foot. She was in a lot of trouble, and the obstetrician really was nonplussed as to what to do. Medication wasn't really indicated, and she couldn't take anything that was too strong, and bed rest was out because she had 2 other children running around the place. And I thought, well, this is going to take a great deal of time. And I said to her, I'm not sure how much I can do here, because really you've got such a severe prolapsed disc. It was quite evident that's what it was, and the reflexes had dropped, and there was all sorts of positive signs to say that this, if she hadn't been pregnant, would have been a neurosurgical case. But we weren't about to send her for surgery, so we had to do what we did. Within 2 treatments, that woman was 100%. Absolutely no signs, no symptoms, normal reflexes, great power, full straight leg raising, and to this day, I don't know why. Sorry.
Could you pull a case out of your filter that didn't go so well, and maybe the same lack of an understanding as to why it didn't go well?
Yes, I mean there are cases that occur. And you say, well, I don't know what's going on here. Something's happening here. I'm not quite sure. And they come in each time, and how are you? No better. How are you? No better. How are you? Maybe a little worse. And that's why I think it's very, very, very important for us as primary care practitioners to actually have the courage to say, stop. Actually, I need more information here. And that's when you send them for the MRI scan or the CAT scan. That's when you send them for the blood test. That's when you actually say, really osteopathy is great at what we do, but nothing's perfect. And at that case, I will send them off for a second opinion. When you're in practice, and you've been in practice for a while, you have a big address book. And it's all the people who are neurosurgeons and rheumatologists, and those are the people that you rely on to support you when osteopathy isn't working well. Sometimes we know about that before we start treating them. Sometimes you start treating them and that's when you discover that they're unsuitable for treatment. And if that's the case, then I will stop and refer.
Dr. Sandler, Dr. Still, Dr. Sutherland, other osteopaths have referenced God or things like a prime mover or nature, today, depending on your background, as being involved. How do you see yourself, or do you see yourself with a role somewhere between some kind of prime mover, the patient, and their illness or their disease? Where do you fit in? Where does Dr. Sandler fit into that role?
As a facilitator, I acknowledge the fact that we are what we are. We have our own limitations. And I acknowledge the fact that spirituality is a reason why people are healthy in themselves. I've been to hospices where people are in the last moments of death. And they've acknowledged, okay, everything comes to an end. I've seen people who come in to see me who are so wounded and so damaged, either psychologically or spiritually, that I have nothing to offer. But if I can look at the corporal, if I can look at the framework, and if I can assess the framework and acknowledge that there is a spiritual component, call it healing. I have no problems with using the word healing at all. Absolutely none. And people are sometimes disturbed because they lack spirit. We're into a generation where the M word, morality, is almost an unknown word. And yet, behaving decently and being a person comfortable within your own skin is very important. And I see people sometimes who are not comfortable. And so I acknowledge, but I'm not a psychotherapist. And just as I'd be very upset if the local psychotherapist started manipulating people's necks, I think we also have to be very careful not to rush into psychotherapy. However, knowing that patient needs counselling skills and referring that patient on for counselling skills is very important, and that's what we should be doing.
Steve, you touched on several times already on psychological damage or emotional damage and spiritual damage. Could you go into that a little bit more, or perhaps what would be the differences between someone who's... I sort of get this flavor from a lot of people I've discussed this with, and I have my own interpretations when things pass through my filter, is what I would say. That person's really spiritually damaged versus they're emotionally damaged. Physical trauma, none of us would argue. You know, you got hit in the head with a baseball bat, and so your head hurts. Some people might say, Buddhists might say, well, you got hit in the head with a baseball bat because you had it coming from the last life. What are your thoughts as far as what does that mean to be spiritually damaged versus psychologically damaged?
I'm not going to try and split that atom
between
spiritual and psychological damage, because our psyche is the reason why we believe or otherwise. But I will say this. If you want to go and look at the link between the psyche and the soma, go look at a dog. Before a dog bites you, its hackles rise. And I see many patients who come in to see me, and their hackles are rising. And I sometimes want to say, when was the last time you bit someone? When was the last time you said to your boss, no, that's absolutely unacceptable behaviour? But we don't do that. We swallow. And when we swallow, it goes in. And it has to come out. And it comes out along that dark dorsal surface. And that's why people come in sometimes with emotional complaints like tension headaches, like fibromyalgia in their shoulders, because they're not allowed, or they're not allowing themselves, the opportunity to let go. Some people let go through the use of drugs or drink. Some people let go through sport. Actually, you know, for me sometimes, if I'm really tense and I'm really angry about something, I go to the driving range and I hit golf balls. I have a very good friend who writes the name of all his creditors on his golf balls and knocks them into the middle distance. Comes back saying, well, that feels really good. Now, you know, we have to, each of us have a way of coping. And if that way of coping for you is with your church, fine. Because copers, people who actually do manage to find a way of dealing with that word, stress, are people who are heading towards health. But stress and emotional or physical or spiritual damage will contribute towards disease, will contribute towards ill health, because it's a block, it's a restrictor. And that's. But I'm not going to split the other atom for you.
I think we might come up with a new therapy. I like the idea of golf balls and creditors, but it could put us out of business. So maybe we should.
No, we're going to have to fix them when they're over swing. So
that's true. That's true. It'll be a two-way street. Steve, if I were a student observing you today, I was a new student in osteopathy, and we were taking a coffee break, and you were going to tell me about the good old days of osteopathy. What would you be talking about?
I'd be talking about the fact that when I was a student, the BSO was very small. You couldn't escape. Your teachers were there all the time, which meant that you had very intensive one-on-one teaching from some of the people who were, you know, supremely gifted at what they were able to do. I think that today the profession is bigger than it's ever been before and still growing, and that's a wonderful thing. I'm part of the architect of that because I've been teaching for the last 30 years. But I think that we have to be very careful to nurture individuality within students in the way that it was done in my day. I think it's no coincidence that out of the people in my year, I was in a big year, there were 13 of us. The year before I only had 6. I think of that 13, you've got 5 people who are teachers of osteopathy. You know, the profession has to grow from roots. But in the same way, we have to grow seeds. And each individual seed needs the attention to bring it up to fruition. And teaching big classes sometimes means that individuals get left behind. And I just feel that as a teacher, it's my responsibility to be as responsible to the individual as it is to the class.
What do you see today that encourages you for the future of our profession? What are you seeing right now that gives you hope that things are going in the kind of direction you're talking about?
The fact that the profession is achieving legality throughout Europe. We, in the UK, had our profession from 1917. But it took until 1993 before the Osteopath Bill was passed in Parliament. I see osteopathy in France, Belgium, Spain, Scandinavia, Sweden, all the way across Europe, developing, offering this service to more and more people. That's encouraging. I see the fact that in the UK there is wider and wider acceptance about what we do as osteopaths as opposed to manipulators, although the perspective is still very much, oh, you're an osteopath, you treat back pain, don't you? That's okay, that gets me a foot in the door. And my response is always yes, and other things. And people are now coming to us with conditions that they would never have presented with even 10 years ago. The whole craniosacral concept has helped change the face of the profession, and the visceral concept is helping to change the face and the flavour of what we do. And I think that the more we can demonstrate the wide range of conditions that we're capable of treating to enable this suffering patient to achieve a better standard of health, the more osteopathy will be accepted as the profession that it was, and I like to think as the profession that's still thought about and promoted all those years ago.
Steve, do you think passion is necessary to do what you do?
Yes. You have to believe in what you do. And sometimes, in my case, if you want to put a negative, I'm too passionate. I'll live with that.
Steve, what are you discovering at this time in your life? You've been teaching for 30 years. In practice, some people might say forever. And you've done an incredible amount of research. What are you discovering now for yourself?
I'm discovering that all those years ago, when I went for my first interview and spoke to Colin Dove about osteopathy, and that this seems like a good idea. I think this will be okay for me. Every single day, I discover that was the best thing that ever happened to me, and that I'm the luckiest person alive.
When someone's been treated by you, is there something that you would like them to know or to feel or to remember from that experience?
No, not necessarily. I think that I'm happy that they're content. I'm happy that they've received a treatment from me as part of a treatment program, and that they walk away and that they'll say to their friend, "Hey, these osteopaths, they're good." That's what I want. My ego is not that, oh, go and see Dr. Sandler. He's absolutely fantastic. I'm not interested in that. I was at one stage when, but now there's enough people, thank God, who are coming to me as patients. I'm not searching anymore for that sense. But it is important that every time we treat patients, that the reputation of osteopathy is improved.
Last question, Steve. If you had one story to tell about a patient, about yourself, about osteopathy, about life, what would it be?
Oh, what a question. The flower seller. There's a guy I've been treating here in this practice for at least 20 years. Lovely guy, very old man now. He sold flowers in the local market from the same pitch that his father, his grandfather, and his great-grandfather sold flowers. He left school at the age of 12. Okay? I said to him, "Oh, your son's going to take it on?" He said, "No, they're failures, they're stockbrokers." And I said, he came in all those years ago. He smoked 60 cigarettes untipped a day and has done all of his life. And he's unfortunately totally unsuitable, therefore, for surgery. I mean, his cardiovascular system is, if you like, shot. "Can you do anything about this? I've got an arthritic hip." "Yeah, okay, fine." And I've been treating him once a month ever since. And he comes in and he's an absolute joy. This guy is an absolute joy to treat. He's grateful, he's comfortable, he's mobile, he still walks every day, he still is independent. Superb. And one day, he said to me, "Here, Dr. S." He said, "I think I've cracked it." He said, "I think I understand." And I said, "What have you understood, Tommy?" He said, "One of us is going to die before the treatment's over." He said, "I hope it's me." He said, "Because if you go first," he said, "what am I going to do?" That is a lovely illustration of why it's great to be an osteopath.
Steve, thank you so much. This has been a real pleasure for me.
And for
thank
me
you very
too.
much.
Thank you very much.